Hello, everyone, and welcome to today's webinar, the 2025 Acute Coronary Syndrome Guidelines. Something old, something new, something borrowed, some things left to do. My name is Jana Petchak, and I am the Senior Program Development Manager for Get With the Guidelines Coronary Artery Disease, or CAD for short. Before we get started, I'd like to go over a few items regarding today's event. This webinar is being recorded and will be sent via email within 2 hours. You can submit questions by typing them into the questions pane of the control panel. We will collect these and address as many as possible during the Q&A session. If you experience technical issues, most can be resolved by refreshing your browser. If the issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in your confirmation email. To view live closed captioning for this webinar, please utilize the hyperlink in the chat. Lastly, I am pleased to announce that we have just received continuing education credit approval for this event. As you can see here, we have continuing education hours for multiple disciplines, including physicians, physician associates, nurse practitioners, nurses, and emergency medical services. Details on how to claim these credits will be provided towards the end of today's webinar. You will also find a handout attached to this webinar in the handouts panel with information on the credits that you see listed here, as well as the slide deck that is being presented today. Our presenter today is Dr. Sunil Rao, who I will be introducing shortly. First, I would like to provide a brief overview of the history of AHA's Get With the Guidelines CAD program and how it can support your facility in delivering evidence-based care to coronary artery disease patients. As you can see here, Get With the Guidelines CAD is one module amongst several that the American Heart Association has developed to assist hospitals in following cardiovascular and stroke clinical practice guidelines. Participation in these programs can have a meaningful impact in several areas, including improved patient outcomes, equitable patient care, staff morale, reimbursement, and return on investment. It goes without saying that every hospital's goal is to provide excellent patient care. However, it can be almost impossible to keep up with the continually evolving research for each and every provider. That is where the clinical practice guidelines and the AHA's Get With the Guidelines program comes in. Developed by expert panels, clinical practice guidelines provide recommendations based on the latest research and clinical evidence for diagnosing, managing, and treating diseases. They help clinicians make informed decisions, reduce variations in care, promote effective resource use, and enhance patient safety. Overall, they serve as a cornerstone for delivering high-quality, consistent patient care. I won't go into great details on the steps of the guideline process, as Dr. Rao will be sharing some details on that. The Get With the Guidelines registry and program modules were created to help hospitals implement and monitor adherence to guideline-directed care. This timeline shows some key highlights or milestones from the Get With the Guidelines CAD program over the years. As you can see here, our first module was launched way back in 2001, with that being the stroke program and registry. That same template then was used to build out the CAD registry in conjunction with the American College of Cardiology in 2005. In 2007, we launched our Mission Lifeline program to really support STEMI systems of care work. In 2011, there were some clinical practice guidelines around percutaneous coronary intervention released that also had STEMI systems of care implications. And here you see a list of several different clinical practice guidelines that have been released over the years. Keep in mind that each time a new guideline is released, we work very closely with our Systems of Care Advisory Group to update both our registry and program to match the latest guidelines. In 2013, we had the STEMI guidelines that were published, followed by the non-ST elevation acute coronary syndrome in 2014. In 2021, we saw the guideline for chest pain management. And then in February of 2025, we just had the guideline for the management of patients with acute coronary syndrome released, which encompasses the unstable angina and STEMI population. So that brings us to today. I am very pleased to introduce to you Dr. Sunil Rao. Dr. Rao is a professor of medicine at NYU Grossman School of Medicine. He is the director of interventional cardiology at NYU Langone Health, as well as the director of the NYU Langone's cardiac cath lab in Manhattan. Dr. Rao was chair of the writing committee that led the 2025 ACS guideline effort. His primary interests in research focus on pharmacologic and interventional treatments for acute coronary syndromes, quality improvement in interventional cardiology, and managing bleeding and transfusion-related complications in heart disease. Dr. Rao has led multiple prospective clinical trials and authored over 300 publications. All right, so with that, I am very pleased to hand things over to Dr. Rao.
Great, thanks so much for that kind introduction. I'm really excited to be here to review the acute coronary syndrome guidelines today. And I've titled this Something Old, Something New, Something Borrowed, and Something's Left to Do, because the guidelines that I'll be reviewing did borrow or carry over legacy recommendations from the prior guidelines where there were no new data generated in a particular topic area. There are multiple new recommendations based on randomized trials that have been done since the release of the last set of guidelines. And then we did borrow some recommendations from the recent revascularization guidelines. And I think what's important to realize is that these guidelines do cover a very broad spectrum of treatment strategies for patients with ACS, but there are still lots of evidence gaps, and I think our job is not done. We still have to generate new evidence, and most importantly, we have to implement these guidelines into clinical practice. So a little bit of a lag. Let me see if I can get these slides to advance. Yeah, I think you might have to give me control of the mouse one more time just to make sure the slides advance.
Go ahead and try again.
Let me try that. Yeah, there it goes. Okay, I don't have any disclosures related to this talk. But the question ultimately becomes, how do you make this guidelines talk interesting? Because I think previous talks around guidelines simply review the tables and they go through all the recommendations. They're basically reading the guidelines to you. And right now it's lunchtime for many of you. It's after lunch for me. I certainly don't want to do that, and I don't think you want to hear someone go through all the tables because you're not going to be able to stay awake. So instead, I'm going to take a little bit of a different approach to these guidelines. What I'm going to talk to you about is the background of the guidelines process, tell you how it works. And then what I'm going to do is try to apply it at the bedside and go through a case presentation. What I think is important is that these guidelines have a really storied history. So one of the earliest guidelines that was developed for unstable angina was a partnership between what was then called the AHCPR, or the Agency for Healthcare Policy and Research, which is now called AHRQ, and academic institutions. In this case, it was the Brigham and Women's Hospital as well as Duke. But what I think is interesting is that some of the things that were developed as part of that guidelines process are still part of how we use what we do to develop recent guidelines. So for example, science-based methodology and expert clinical judgment, that comes into how we craft our recommendations. Literature searches. This is not someone sitting in a back room kind of coming up with how they treat ACS. The writing committee does extensive literature searches, conducts evidence reviews, actually creates evidence tables to inform these recommendations. And then the document undergoes multiple rounds of peer review. So what you're seeing and what you're reading with the ACS guidelines is really the culmination of a 14-month process of intense discussion, debate, and consideration of the highest levels of evidence, as well as a very, very intensely peer-reviewed document. So when we think about the guidelines and how it fits in with the overall process, it's a collaboration, a close collaboration between the American Heart Association and the American College of Cardiology. There is something called the Joint Committee on Clinical Practice Guidelines. Catherine Otto is the chair, I'm the chair-elect. This is the committee that is composed of representatives from both organizations, and they oversee all of the guidelines. And each guideline has a writing committee that's chosen by the Joint Committee and vetted by both organizations. And that writing committee will have representatives that have a variety of clinical expertise. And what we try to do for each guideline is to make sure we have representation from clinical specialties that have anything to do with that particular subject matter. So for example, in acute coronary syndrome, on our writing committee, we had interventional cardiologists, general cardiologists, we had emergency medicine personnel, we had emergency room physicians, we had cardiac surgeons, and we had patients. And patients are also on these writing committees because they lend a very, very useful perspective on what it means when we start formulating these recommendations and what it means to patients. And then there's a separate peer review committee that's independent of the writing committee that will have co-chairs, and then they will also review the document. And for the acute coronary syndrome guidelines, we had 2 rounds of peer review. I think we had over 250 comments that we had to respond to. And so these guidelines have been vetted in a very, very rigorous way. One thing I think it's also important to think about is that there are certain ground rules that we have when we formulate these guidelines, and we have to adhere to those ground rules. One of them is that we have collaborating organizations. So for the acute coronary syndrome guideline, we invited the American Association of Thoracic Surgeons, the American College of Emergency Room Physicians, the National Association of BMS Personnel, SCAI, which is the Interventional Professional Society, as well as the Society for Thoracic Surgeons, to be collaborators on this document. What that means is that they can nominate writing committee members. Unfortunately, the AATS and STS did not respond to the invitation. So the collaborating organizations on this particular document comprises 3 organizations, the 2 emergency medicine specialties organizations and the interventional cardiologists. And then we have reviewers, of course, from these different organizations as well. Despite the fact that the AATS and STS did not nominate writing committee members and did not collaborate, we did have 2 cardiac surgeons as writing committee members, one of whom was the co-chair. Mark Rule is a cardiac surgeon who was the vice chair of these guidelines, along with Michelle O'Donoghue. And again, without their help, we would not have been able to get this document across the finish line. So when we started thinking about the nuts and bolts of this document, let's see if I can get this to advance here. This is the document that we're going to be talking about. So I encourage everyone to download a copy from the circulation website and go ahead and read it. And when we were thinking about, in the early stages of this guideline, we had a decision to make. Remember, the last set of guidelines came out 11 to 12 years ago. So think about how the evidence has really changed and the landscape has changed since that time. And one of the challenges is, what do we mean when we say MI? What do we mean when we say acute coronary syndrome? We've recognized that it means a lot of different things. It can mean an MI caused by spontaneous coronary artery dissection. It can mean MINOCA, which is myocardial infarction with no obstructive coronary arteries. It may be type 2 myocardial infarction, right? So we had to focus, and what we decided to do as a writing committee is focus on type 1 myocardial infarction. And we did not include things like type 2 or MINOCA. The reason we made that decision is for 2 reasons. One is that all of the landmark trials considered in ACS had the underlying assumption that the patients included had type 1 myocardial infarction. Now, it's entirely likely, of course, that type 2 myocardial infarction and MINOCA were in fact in those trials, but the fundamental assumption was that they were type 1 events. The second reason is that MINOCA and those other entities are very, very nicely covered in the chest pain guidelines. So when we talk about acute coronary syndrome or myocardial infarction for the guidelines and for this talk, we're really talking about type 1 myocardial infarction. And of course, that for the first time, we've combined NSTEMI and STEMI. And those 2 entities have some overlap in the way they're managed with respect to antithrombotic therapy, perhaps, but the timing of interventional procedures may be different for those 2, but we wanted to make sure that it was a one-stop shop for physicians and patients and any other readers who want to look at these guidelines for the management of both entities, STEMI as well as non-STEMI. Sorry about the delay in the slides here, but let's take this to a case now, and then we can talk about the recommendations. So this is a fairly generic case, but I suspect that those of you who are caring for patients at the bedside probably see patients like this all the time. A 75-year-old female with a history of hypertension, type 2 diabetes, atrial fibrillation, and dyslipidemia presents with NSTEMI. She has a high sensitivity to troponin that's elevated and it's rising. She's 59 kilograms. Her hemoglobin is 8.5. That will become relevant. And she has acute kidney injury, or CKD, let's say chronic kidney disease, a creatinine of 1.6. She gets an echo in the ER that shows normal LV function, no valve disease. So using that as the backdrop, let's talk about how we can apply these recommendations specifically to this patient. And we're going to go through what some of the legacy recommendations are, what the new recommendations are, what we borrowed from other guidelines, and then some remaining gaps. Certainly, this presentation is not going to encompass every single recommendation in the guidelines. So again, I encourage all of you to read the document. And again, give us your feedback, see what you think about it and what we got right, what we got wrong. So let's talk about how we manage this patient in the ER. And this is the something old part. This is stuff that we took from the previous guidelines because there were no new data, and we adopted it into the current set of guidelines. The first is, we really need to start using more potent antiplatelet agents, the oral antiplatelet inhibitors, or oral antiplatelet agents like prasugrel and ticagrelor based on large randomized trials. They are better than clopidogrel in terms of reducing major adverse cardiovascular events and stent thrombosis. But the trials that evaluated these agents were slightly different. So prasugrel was largely a cath lab-based trial. These patients were undergoing invasive evaluation, and the vast majority of them underwent coronary stenting. Ticagrelor, on the other hand, was studied upstream of the cath lab. So some of those patients got PCI, some of them got medical therapy, some of them got bypass surgery. So if you have a patient for whatever reason who is not going to undergo planned invasive evaluation, ticagrelor is recommended over clopidogrel. And note that prasugrel is not mentioned in that context because that's not the way it was studied. Now, certainly if you don't have those agents, single antiplatelet therapy should not be used. So aspirin alone is no longer, and has not been since the 2013 guidelines, the sole antiplatelet agent to be used. These patients do require dual antiplatelet therapy. So if you don't have the newer agents, clopidogrel is what's recommended in addition to aspirin. Now, the question then also becomes, when do you give the agents? I worked at an institution previously where no one was loaded upstream, that is upstream of the cath lab, with these newer agents. I now work at an institution where every MI patient gets loaded with oral P2Y12 prior to the cath lab. And I suspect that that's probably true of the country. It's probably half and half. And that's because the trials that have looked at upfront or upstream loading of P2Y12 inhibitors have not necessarily shown a benefit of those agents when studied in a broad population. But there seems to be some advantages of giving those drugs early, particularly if there's a delay to the cath lab. So if there's a timing of the angiography is anticipated to be more than 24 hours, so let's say the patient comes in on a Friday, we gave it a class 2B recommendation to be treated upstream so that you can prevent those events prior to going to the cath lab. Now, of course, patients are being taken to the cath lab very, very quickly. So in that context, it really probably doesn't make sense to, or at least doesn't have much of an impact to try and load patients early. So let's switch gears now to anticoagulation. We talked about antiplatelet therapy. What about anticoagulation? And here we're really talking about two separate situations that are related. The first is upstream of the cath lab. So you're seeing the patient in the ED, like that patient that I mentioned. That patient does need antithrombin therapy right away to prevent recurrent infarction before they even get to the cath lab. And here, 3 agents get a class 1 recommendation. Again, these are carried over from the prior guidelines. And I should mention that one of the ground rules of these guidelines is that if there's a legacy recommendation, there has not been new data, you have to carry over those recommendations. And certainly, I think it's reasonable to do that. In this case, fondaparinux, heparin, and low molecular weight heparin all get a class 1 recommendation for upstream therapy prior to the cath lab. But once you get to the cath lab, things change a little bit. And what's interesting is that the randomized trials have shown that fondaparinux should not be used in the cath lab. That's because of an increased risk of catheter thrombosis. But the other agents like heparin and low molecular weight heparin are still okay to use in the lab. Enoxaparin gets a 2B recommendation. Bivalirudin, interesting, there is some new data. There are some new data, I should say. That's a BRIGHT-4 trial, which is a large trial of patients with ST segment elevation MI, all of whom got primary PCI, who were randomized to bivalirudin versus unfractionated heparin. 95% use of radial approach in that trial. And in that trial, there was a prolonged infusion of bivalirudin after the stent went in for about 4 hours or so. So bivalirudin gets a class 1 recommendation for primary PCI and STEMI, class 2B for NSTEMI. So this patient that we have, again, those are the strategies to be used for antiplatelet therapy up front, as well as anticoagulation. Here are the data with this BRIGHT-4 trial that led to this uptick or upgrading of the recommendation for bivalirudin and STEMI. 6,000 patients randomized, like I said, 95% radial artery use in this trial. And I think it's very difficult to argue with the results of this study. This study showed that there was a significant reduction in 30-day death or bleeding among patients who got bivalirudin. And there was also, if you look at the second co-primary endpoint, which was reinfarction and stent thrombosis, again, a reduction in that combined endpoint with bivalirudin. So again, this is in the context of other trials that have shown really no difference between bivalirudin and heparin, which is why both agents get a class 1. You may say, well, gosh, what am I supposed to do? Well, I think the idea is that use what you're most comfortable with in the cath lab. Both of them get a class 1 recommendation. So there are options for these patients who are going to the cath lab with respect to anticoagulation. So now when we start talking about that patient that I mentioned, so we've given them oral antiplatelet therapy, we've given them anticoagulation. Now the question is, number one, do we take them to the cath lab? And number two, when should we take them? And those are two kind of separate but related questions. So who do you not take to the cath lab? And who can you sort of say, well, we want to do some kind of a non-invasive evaluation? Well, these are the patients on the right-hand side of the slide, the lower risk ACS. So these are what we would consider unstable angina, a vanishingly small group of patients now in the era of high sensitivity troponin, but we have them. These are patients with low GRACE risk scores. Their troponin is not elevated. They're completely stable. They don't have persistent chest pain. Their EKG is stable. Those are patients where you can do either a new routine invasive, you can take them to the cath lab, or you can sort of say, you know what, I'm not going to take them to the cath lab. Instead, I'm going to do some kind of non-invasive risk stratification, like with the CTA or with a stress test. If that's positive or the CTA suggests coronary disease, then those patients should undergo coronary angiography before hospital discharge. For everybody else, though, intermediate to high risk to very high risk, those patients really should get a routine invasive evaluation in the cath lab. The timing of that depends on the acuity of the patient. If they're very unstable, ongoing chest pain, shock, etc., they need to go right away. If it's not that and they're high risk or intermediate risk, you really should be taking to the cath lab either within 24 hours or within 72 hours, again, depending on the patient risk. Nowadays, I think the time to cath is very, very short for most of us. Those patients are usually going within 24 hours. So, we've covered oral antiplatelet therapy. We've covered anticoagulation. Let's go back to our patient. So far, we've got all green boxes, all class 1s. We're doing pretty well. This patient was loaded with aspirin and got ticagrelor. It's a class 1 for agents, class 2B for timing. I'll give us that. We'll grade on a curve here, give us a class 1 for that box. Antithrombin therapy, this patient was treated with IV unfractionated heparin, another class 1 recommendation. And then she's going to go to the cath lab within 24 hours. Her elevated to high sensitivity troponin makes her into that intermediate to high risk category. So it's a class 1 to go. Within 24 hours is a class 2A for timing. So far, so good. We're doing pretty well. So now we've talked about what we carried over from prior guidelines. What's new? Well, there's a tremendous amount that's new in this guideline. I'm going to try my best not to go through all of them, but try to make it relevant to what I think is important for everyone to know about what some of these new recommendations are. The first is, what do we do with patients who have multivessel disease who come in with STEMI? In the past, there was a variety of different practice patterns. You would treat the infarct-related artery, so these patients are undergoing primary PCI within 90 minutes. And then you sort of say, well, the other arteries also have significant lesions. Some people were doing PCI on those before hospital discharge. Others were using physiology to determine whether or not that lesion should be intervened on, so using FFR, for example. Or some people were saying, I'm just going to follow the patient, see how they do. If they're having recurrent chest pain, we'll come back and do it. And still others are doing Strub-Max stress tests at 30 days or something to see if there was an abnormality. Well, there were a couple of smaller trials that suggested doing PCI of these non-infarct arteries was beneficial, but this was really the big one. This is COMPLETE, which is a large study of 4,000 plus patients with ST elevation MI and multivessel disease, all of whom had successful PCI to the culprit lesion. And then they were randomized to complete revascularization versus culprit-only revascularization. And the median follow-up was 3 years. There were 2 co-primary outcomes that you can see listed here. Now, this trial was very, very important because it showed a significant benefit of complete revascularization in patients who were randomized. These patients had a lower risk of cardiovascular death or new MI. But interesting, there was a second co-primary outcome, which also was beneficial in the complete revascularization. There was a lower risk of cardiovascular death, recurrent MI, or ischemia-driven revascularization. So that gets a class 1 recommendation in the guidelines now based on this large randomized trial. So let's go to our guidelines. So here's the algorithm for patients with management of non-infarct-related artery and STEMI. So you have a patient with STEMI and multivessel CAD, and they're hemodynamically stable. Now, one thing I should mention is that none of these patients were candidates for bypass surgery, okay? So they were not eligible for the trial if they were candidates for bypass surgery. So certainly if they have very, very complex disease, you know, left mains, very complex stuff, you know, consideration should be given to bypass at some point. But if they qualified for the trial, they had low complexity multivessel disease, then those patients should get PCI of non-infarct related arteries to reduce the rates of death. It's a class 1 recommendation. When should you do it? Should you do it all at the same time, or should you do it in a staged fashion? Well, one trial suggested that doing it all at the same time is more beneficial, but that trial had some issues with respect to parsing out, you know, the effect of the intervention on recurrent MI. In the trial that I just mentioned, the median time to stage PCI was about 14 days. So we gave a class 2B recommendation to do non-infarct related arteries all at the time of primary PCI. If it's a simple lesion, it's during the day, you think you can get it done relatively successfully, then go ahead and do that non-infarct related artery after you've treated the infarct related artery. What about NSTEMI? Well, NSTEMI is a little bit of a different animal. There were some patients who likely had no ST elevation, but they had circinfarcts in that complete trial. We still gave multivessel PCI a class 1 recommendation. Part of the challenge in NSTEMI is, what do you call the culprit artery? There are some data that suggest that 25% of the time, the lesion that we treat is not the culprit. We're just not very good at picking it up in the cath lab. And certainly, again, if they have complex disease, bypass surgery should be recommended. What's interesting is that there was a randomized trial that looked at using physiological assessment of a non-culprit stenosis. So this would be things like FFR or IFR to measure whether a lesion is significant in the cath lab. That trial, interestingly, showed that there was no difference between using physiology and just using the angiogram. This is very different from the stable angina population, I might mention. So because that trial showed no difference, we decided, you know, you can consider using it, physiology guide revascularization decisions, but because of that negative trial, it's really a class 2B recommendation in the latest iteration of the guidelines. So complete revascularization is really what the order of the day is based on the latest randomized trial. There is another trial that's going on right now called Complete 2 that is randomizing patients to either physiology guided non-culprit or angiography guided non-culprit. That trial won't report out for another 3 years, so I expect that it will probably inform the next iteration of the guidelines, not this one. The other big trial that informed our guidelines, and big I don't mean in terms of sample size, but big in terms of its impact, is the Danger Shock trial that was released last year. So Danger Shock was a trial that of 355 patients with STEMI-related cardiogenic shock. They were randomized to something called the microaxial flow pump, commercially known as Impella, versus standard care. And this trial took 10 years to enroll these patients because it's very, very challenging to enroll patients with shock. But it was really a remarkable study because in the patients who were randomized to the microaxial flow pump, there was an absolute 13% reduction in 180-day mortality. So this is primary endpoint of 6-month mortality. So there were more patients who were alive who got randomized to the microaxial flow pump. For those of you who remember the old shock trial that resulted in a class 1 recommendation for taking patients in shock to the cath lab, that was exactly this, almost similar absolute risk reduction, 13% absolute reduction in 180-day mortality in that trial. So interesting. So, you know, we struggled with this a little bit. You know, should we give this a class 1 recommendation? Well, there was no free lunch in this trial. The patients who got randomized to the microaxial flow pump or the Impella did have a higher risk for moderate or severe bleeding, higher risk for limb ischemia, higher risk for renal replacement therapy and sepsis. Some of this may be that they lived long enough actually to get these complications. There's a bimodal distribution of mortality in this trial. Much of it was very, very early, and then it was later on. But there are some risks associated with the device. And in the guidelines, we have to consider both benefits as well as risks. So I think we got it right for the guidelines recommendation in this. In selected patients, and in that trial, they were very selected. These are patients who, you know, had a good chance of survival from cardiogenic shock. We gave a class 2A recommendation to selected patients with STEMI or severe or refractory cardiogenic shock. Insertion of the Impella or the microaxial flow pump is reasonable to reduce death. Note that this is the only mechanical circulatory support device that gets a recommendation in the guidelines. Intra-aortic balloon pump and ECMO, routine use of these devices is not recommended because of no benefit. That's based on 2 large randomized trials, the IABP shock trial as well as ECLS shock, that showed no benefit of these agents or of these devices. Now, we all have had patients in our clinical practice who have benefited from a balloon pump or benefited from ECMO. So that's why the wording of the recommendation is very careful. This is the routine use. That is, if someone comes in with shock, it should not be your protocol that they all get a balloon pump or they all get ECMO, because that does not seem to be a beneficial strategy. In selected patients, it may be beneficial. We simply don't have the data to make that recommendation. So that's a new recommendation in the guidelines. Now, the other thing that we should talk about is intracoronary imaging. So intracoronary imaging, the use of intravascular ultrasound or OCT to guide stent placement, gets a 2A recommendation in the 2021 guidelines for revascularization. But since 2021, there have been several randomized trials that have reported out that showed that imaging-guided PCI reduces the risk of major adverse cardiovascular events, and in one of the trials actually reduced mortality. So there are new data. So we can't carry over that last recommendation. We have to give it a different recommendation. And in this nice meta-analysis that was done by Greg Stone, reported in the Lancet, of 15,000 or close to 16,000 patients, there was a benefit of IVUS or OCT over angiography with respect to all-cause mortality. So that is very difficult to ignore. So now the ACS guidelines say that for coronary stent implantation in complex lesions or left mains, intracoronary imaging gets a class 1 recommendation. For those of you who work in cath labs, you may be wondering, why did we word it that way, left main or complex lesions? Shouldn't we be using it in everybody? As a practicing interventional cardiologist, I would say, yes, you should be using it in everybody, but in the guidelines, we're bound by the language that's used in the randomized trials. And in these trials, there were the inclusion criteria included either left main or complex lesions, which is why it was worded that way. But certainly, you know, I think that in order to integrate it into your workflow and get familiar with intracoronary imaging, you really should be doing it in everyone. Another trial that I personally was involved with, I was on the steering committee of this trial, was the MINT trial. And this is a really interesting study. It was led by Jeff Carson in New Jersey. Really took us a tremendous amount of effort to get this trial done. 3,500 patients with STEMI or non-STEMI and a hemoglobin less than 10, randomized to keep their hemoglobin at 8 with red blood cell transfusion or transfuse them up to a hemoglobin of 10 or greater with transfusion. Now, what's happened is a remarkable change in practice. When I was in training, all MI patients got transfused to 10. Then there was some observational data that I was involved with, as well as others, that showed that an association between that hemoglobin of 10 and an increased risk for worse outcomes. So then everyone stopped transfusing to 10. They said, let's just keep everybody at 8. But this is really the most adequately powered randomized trial that compared these two transfusion thresholds in patients with MI and anemia. And you know, unfortunately, this trial was not completely definitive. We just missed statistical significance. But the reality is all the components of the primary endpoint favored the liberal transfusion. So in other words, aiming for a higher hemoglobin was better. Cardiac death was statistically significantly better when you maintain the hemoglobin at 10. So this is new data, right? I mean, these are the only data really with red blood cell transfusion in MI. So we had to incorporate it into the guidelines. And what we did was we gave it a class 2B recommendation in patients with ACS and acute or chronic anemia. Blood transfusion to achieve a hemoglobin of 10 or greater may be reasonable to reduce cardiovascular events. I'll remind you that the patient that we're talking about in this talk had a hemoglobin of 8.5. So if you wanted to transfuse her, it would be a class 2B recommendation to give her enough blood to get that hemoglobin up to 10, after, of course, you investigate the reason for her anemia. And then the other set of randomized trials, that really there have been numerous randomized trials now in this space, is what do we do with discharge antiplatelet therapy? I talked to you about admission antiplatelet therapy. What do we do when the patient's ready to go home? Well, I think the legacy recommendation of 12 months of dual antiplatelet therapy still holds, because the question, which I think everyone asks, which is how long do I need to treat, really needs to be turned on its head a little bit, because the question is not how long do I need to treat. The question is, when is it safe to discontinue the P2Y12 or the aspirin? That's really the question. And I think if the patient was not high bleeding risk and they were tolerating the dual antiplatelet therapy, we would really recommend treating those patients for 12 months because that's what was studied in the randomized trials. But there are 3 strategies to reduce bleeding. The first is to treat the patient with DAPT for 1 to 3 months and then drop the aspirin and use ticagrelor monotherapy. That's class 1 based on the Twilight trial. What about the patient who requires oral anticoagulation? Remember, the patient that I presented to you at the beginning of this has atrial fibrillation, so she's going to need an oral anticoagulant. What do we do with those patients? Well, we discontinue the aspirin based on large randomized trials that have shown that this is really the best strategy to reduce bleeding risk without sacrificing ischemic benefit. And so generally, treat 1 to 4 weeks with triple therapy, then drop the aspirin and continue with single antiplatelet therapy with oral anticoagulation. The agent that was studied most commonly in those trials was clopidogrel. The other strategy gets a class 2B recommendation is to de-escalate the potency of the P2Y12. So we talked about treating these patients with ticagrelor or prasugrel. After some period of time, when the patient is stable, maybe it's 4 weeks, maybe it's 3 months, you can de-escalate that ticagrelor or prasugrel to clopidogrel and continue that for at least a year. Then what about the patient who's high bleeding risk? And there's an asterisk there because in the guidelines, we do talk about what high bleeding risk means. This would be the patient who requires oral anticoagulation. They've had a prior bleeding event. They've got an upcoming surgery. Well, in those patients, you can stop either the aspirin or the P2Y12 1 month after their PCI and continue with single antiplatelet therapy. These guidelines were too late, or I guess the trial that compared aspirin versus P2Y12 was too late for consideration in these guidelines, and that trial was released at the ACC meeting this year, suggesting that continuing with clopidogrel rather than aspirin as monotherapy may be a bit beneficial. I suspect that trial will probably inform the next iteration of the ACS guidelines because it is important data, and it may be that aspirin is no longer the agent of choice. So let's go back to our patient. We talked about how so far we're doing pretty well. We've got all green boxes across the board here, all class 1s. Well, I was involved with MINT, so I'm going to go ahead and transfuse her to a hemoglobin of 10. That's our 1 orange box, class 2B. If she goes to the cath lab and gets a PCI, well, it's a class 1 recommendation to use intracoronary imaging, so that gives us a class 1. And then if she's got multivessel CAD, I'm going to punt here a little bit. She's an NSTEMI. I'm going to enroll this patient into complete 2 as a randomized trial so we get more data. Okay, so far so good. What do we borrow from other guidelines, recent guidelines? Well, I think we borrowed a lot from the revascularization guidelines because they were the most recent ones. What did we borrow? Well, we still gave radial approach compared with femoral approach for cardiac catheterization and PCI, class 1 recommendation based on large randomized trials that shows that radial approach reduces bleeding risk, vascular complications, and in the ACS population reduces mortality. And then the other things that we carried over from the revascularization guidelines have to do with shock. Many patients who have multivessel disease will unfortunately develop cardiogenic shock when they have a STEMI because they have that acute infarct-related artery and then they've got all that other disease that may be jeopardizing their ventricular function. Now remember, we talked about what to do with multivessel disease in the stable patient with STEMI. What do you do with the unstable patient, the patient who's in shock? Well, we used to think we should just open all those arteries up because we're supporting the patient with more blood flow. Well, it turns out that was exactly the wrong thing to do. So in a patient with multivessel disease and shock, it's a different recommendation compared with the stable patient. In the patient who has multivessel disease and shock, they have worse mortality, worse renal failure, and worse bleeding. So we should not be pursuing multivessel PCI in the patient in shock. Instead, what we should do is open the infarct artery, provide mechanical circulatory support if they're a candidate, and then wait for them to stabilize, at which time we can readdress that multivessel disease. And so based on this particular trial, if we go back to our nomogram here, or our algorithm, if you've got the patient who has STEMI with multivessel CAD, and they're not hemodynamically stable, in fact, they have cardiogenic shock, then routine PCI of non-infarct-related arteries gets a class 3 recommendation harm because you're actually worsening their outcomes. So that's slightly different depending on the patient presentation. If they're stable versus having shock, that is quite a bit of a difference there in terms of the recommendation. So let's go back to our patient. She underwent cath with left radial access. You can see she's got an LAD lesion that undergoes IVUS-guided PCI with a very, very good result. So while we can all give ourselves high fives, Our job is not done yet because we've treated this patient's acute coronary syndrome with adequate antiplatelet therapy, antithrombin therapy, and we've revascularized her, but we still have a lot left to do. We've got to make sure that this patient does not come back with another acute coronary syndrome and that we get her on good secondary prevention so that we can prolong her life. We have to educate her about her coronary disease and make sure she has all the information on her procedural results, counsel her when can she go back to physical activity. If she's a smoker, make sure she stops smoking, counsel her about the diet and regular exercise, make sure she's got all of her medications and explain what those side effects can be. I did not talk to you about lipid lowering therapy just in the interest of time, but lower is better with respect to LDL. If the patient has an LDL of 70 and they're already on a statin, we recommend non-statin therapies to get that LDL down to 55, whether it's ezetimibe or PCSK9 inhibitors. We give annual influenza vaccination a class 1 recommendation based on a randomized trial in MI patients who are randomized to get the flu shot or not get the flu shot, showing that the annual flu shot actually reduces MACE in patients who've had an MI. So those patients should get vaccinated against the flu. And then, of course, you have to make sure that you refer these patients to cardiac rehabilitation. That's also a class 1 recommendation that's been shown to improve outcomes. So, I think we're ready to discharge this patient and we're ready to get her back to her environment. But we need to start thinking about, what other areas do we need to focus on for future iterations of the guidelines. I'm sorry, this slide presentation seems to be stuck here a little bit. Let me try one more time and see if I can get the slides to advance. Let's see here. So, well, I can speak to these issues, which is, I think we've done a pretty good job with the guidelines in terms of considering the evidence, right? I mean, in the past, I think we've had some criticism that a lot of our recommendations were not based on randomized clinical trials, but in fact were based on, sort of expert opinion. Well, it turns out that that's been quite a change since the 2013 guidelines. In the 2013 guidelines, let me see if I can get this slide to advance here. The 2013 guidelines, I think only 27% or something were based on randomized clinical trials. In the current iteration of the guidelines, 66% are based on randomized clinical trials. For those of you who are looking at the ESC guidelines, there are some differences. I've kind of outlined them for you here on this slide. For the most part, they harmonize. There are some details that the ESC guidelines get into that we don't get into. There are areas that the guidelines for the ESC give specific recommendations that we've mentioned in the supportive text. So, for example, the timing of how long you should treat with triple therapy gets a specific recommendation in the ESC guidelines. We just kind of mentioned it in the text. The ESC guidelines give a class 2A, for example, to 1 week to 1 month for triple therapy, whereas we just put it in the text and say you can do 1 week to 1 month. But I think, for the most part, the good news is that we're all looking at the body of evidence in kind of a similar way when we're formulating these guidelines. Jen, I don't know if you can advance the slide one more here. It might just be that some of the animations are dragging it down a little bit. Yeah, so here are the future directions. There's still a lot more work to be done, right? We have several unanswered questions. What's the role of inflammation in acute MI? There are several anti-inflammatory agents that are being studied right now in large clinical trials. Colchicine, for example, has been studied largely in the stable CAD population, not in the MI population. Other newer mechanical circulatory support devices are being developed and are undergoing randomized trials right now. Those may be incorporated into the guidelines depending on what the results are. So again, there's a whole section in the guidelines on evidence gaps, and I encourage all of you to read them. I suspect you know what they are because you're taking care of patients. But again, these guidelines are very relevant for the time being, but the world moves so quickly that they will need to be updated in the next few years. So I can go to the next slide here. Yeah, so here's the evolution in the guidelines, as I mentioned. The 2014 guideline, only 15% of the recommendations were level of evidence A. I mean, it's kind of pathetic. And a third were level of evidence C, which is, not great evidence. But again, it's been 12 years, lots of randomized trials. If you go to the next slide, I'll show you that in the latest iteration, we had a lot more evidence to deal with, to examine. 27% are now level of evidence A, only 20% level of evidence C, and 52% level of evidence B. Remember that level of evidence B does not necessarily mean that it's not randomized data. It just means that there may be one randomized trial, but still it's better than no randomized trials. And if you go to the next slide, we'll show you that 66%, 2/3 of the recommendations in our current guideline are based on randomized trials. So I'll wrap up here and we'll have 15 minutes for comments and questions. The 2025 ACS guidelines summarize the evidence-based to improve outcomes. That's what it's really all about. It's the first update in 12 years, and it includes contemporary randomized trials, and we incorporated both NSTEMI and STEMI into the same document. The foundational strategies haven't changed. It's still about antiplatelet therapy, antithrombin therapy, and taking patients to the cath lab. But there have been several new recommendations in these guidelines since the last iteration, new treatment approaches for multivessel disease, depending on whether the patient is in shock or not, some guidance around how to deal with anemia, intracoronary imaging, as well as cardiogenic shock. But the next challenge for all of us, now that this document is available, is really about implementation. And how do we do that, leveraging the latest technology tools that we have in electronic health records so that most patients are getting guideline-directed strategy for treatment, rather than the fewest patients doing that. Because I think if we apply guidelines recommendation, we really will see an improvement in our patients' outcomes. So again, thank you very much for the invitation to present today. I appreciate everyone's attention, and I'm happy to take any questions or comments. I do want to thank my vice chairs, Michelle O'Donoghue and Mark Rule, the ACC and the AHA staff, as well as the writing committee, and then the peer reviewers. Thanks very much.
Thank you much, Dr. Rao. And as a reminder to attendees, there is still time to enter questions using the question pane, but we do have a few to start with. Did the committee consider replacing STEMI and STEMI with the new occlusive MI versus non-occlusive MI paradigm that many have been talking about?
Yeah, great question. That has come up. So we did talk about it. The problem is that, again, there are some ground rules for the guidelines, which is we have to include the terminology that was used in the randomized trials. All the randomized trials that we considered none of them actually use the OMI versus no MI classification. I suspect that will replace the STEMI and NSTEMI classification that we're currently using, but until the trials incorporate that, unfortunately, we just can't do it in the guidelines because, again, we have to be sort of adherent to what the randomized trials have used.
Thank you. The next question, as a referring facility, we struggle with giving P2Y12 inhibitors because the receiving interventionalist does not recommend to administer. How can we approach administering this medication prior to transfer?
Yeah, it's a great question, and I think a lot of folks have struggled with that because, again, maybe it's not the interventionalist, maybe it's the cardiac surgeon, because you have to wait a little bit when you administer some of these agents because they last so long. It can increase the risk of surgical bleeding. And again, that's, I think, why practice patterns are so split. I think the last time I looked at the registries, it was kind of 50-50 or close to that. Some centers routinely load, others don't. But again, if you look at the data, there are observational data and probably mechanistic data that suggests that upstream therapy is beneficial. It's been very, very difficult to show in the randomized trials, which is why we said we did not give a class 1 recommendation to upstream therapy. Again, the randomized trials have not shown a benefit, but we said, it may be reasonable if the patient has a delay to cath. So if it's not going to be for a couple of days, you probably don't want to leave that patient uncovered with just one single antiplatelet agent. And that's where DAPT may really have a benefit. Remember, the trials that have looked at upstream therapy, not as in a randomized fashion, but just as part of the protocol, was CURE, right? CURE, which is very old now, published in 2001, randomized patients to upfront clopidogrel plus aspirin versus aspirin alone, but the median time to cath in that trial was 5 days. No one is really waiting 5 days to cath anyone anymore. So it's a little bit of a different environment now. So I think that there really aren't any strong data to encourage preloading. It ultimately comes down to what your local practice pattern is.
Very helpful. How should we manage patients that cannot afford ticagrelor for DAPT upon discharge?
Yeah, so great question. We didn't consider cost or cost effectiveness in this particular guideline. There is a move towards doing that in future guidelines. And part of the reason why it's taken so long to consider the costs is that costs are very dynamic.
they may be different depending on what health system and what insurance coverage you have. Obviously, the costs change over time. So it makes the document, a little bit harder to have some kind of a lasting impression. But having said that, this is a challenge that we all deal with. And I think in those patients who can't afford to take those drugs, it is going to be important to make sure they're covered with something. So de-escalation to clopidogrel is a very, very reasonable strategy. And in fact, prasugrel now is also generic, costs about the same as clopidogrel. So you can even, I don't want to call it de-escalate, but maybe make a lateral move to prasugrel as long as those patients don't have the 3 black box warning contraindications: age over 75, prior stroke TIA, or body weight less than 60 kilograms.
Thank you much. Another question. I know this guideline replaced the 2016 guideline. I'm not sure exactly which one they're referring to there, but are all others still needed, or will this replace any of the other clinical practice guidelines?
This will, in fact, we talk about which guidelines it replaces in the opening of the document. So yeah, this does replace and retire the prior ACS guidelines. So those recommendations in the 2013 and 2014 or 2012 and 2013 guidelines for STEMI and NSTEMI no longer apply.
All right, thank you very much. And then final question here, in the new 2025 guideline, it mentions under the analgesic section that rapid and effective pain relief remains an important treatment goal to prevent sympathetic activations. Is this a new goal for the 2025 guideline? They mentioned they don't see it in previous guidelines.
Yeah, it's a great question. So notice we didn't make it a formal recommendation. It's in the document, largely because I think that there are some recommendations that are just part of kind of good patient care and good clinical care that we wanted to include. So I think that even though it wasn't included in the prior guidelines, I would argue that many of us were probably practicing that way anyway, and that it would have been relevant back then as well. But no, it's not a formal recommendation, but it does, I think, apply to patients and to make the process of treatment a little bit more patient-centric.
All right, thank you very much. I see that we are getting a little tight on time here, so other questions we'll do our best to address after the webinar. And just a few more closing details. Once again, of course, Get With the Guidelines CAD is more than a registry tool. Because of the consultative nature and quality improvement programming, we see high-performing hospitals across the country leverage Get With the Guidelines for many goals. Of course, a few of the important ones here being improving patient outcomes, working closely with our quality program consultants to actually implement the guideline-directed care and monitor adherence to that. A few other things, the ability to set system-wise standards, improve your regional systems of care, sharpen your competitive edge with the awards and recognition, et cetera. And finally, most importantly, advocate for your CAD program, and that really comes down to your CAD patients. So if you are a site that is not using our registry yet, we would love to have you come on board and we can walk through you with implementing these latest clinical practice guidelines. A quick reminder as well on some resources that we have. You can go to the Professional Heart Daily website, and I have a QR code here if you wanted to scan that, or you access it in our handout section. And it takes you not only to the acute coronary syndrome guidelines, but many other guidelines covering different cardiovascular and neurovascular disease processes, and as well as resources that accompany those. And then two, we have the Guidelines on the Go app, which is available to both Android and Apple users in your, download them in your app store. And then finally, regarding the continuing education credits, you will receive an email shortly after the webinar has concluded with information that will look very similar to what you see here on how to go into our professional education hub and be able to download your certificate for your specific type of continuing education credits. If you have any questions on this process, once you receive the email, feel free to reach out to the number that you will see listed in the Need Assistance section, or to us that send the email to you. A very special thanks to Dr. Rao for delivering an informative and excellent presentation. Also, thank you to everyone who attended. Once you leave today's webinar, you will receive an email with a short survey. We would appreciate it if you complete that survey and provide your feedback. You will also receive a follow-up email within 2 hours with a link to view the recording of today's webinar. On behalf of the American Heart Association and Dr. Rao, thank you so very much for joining us, and have a great rest of your day.